Welcome to Life by a Thousand Cuts, a podcast series about skin cancer surgery. I am your host, Associate Professor Tony Dicker, and in each episode, we'll share practical insights to support your skin cancer surgical practice, from clinical tips and case studies to journal reviews and interviews with skin cancer colleagues. Today, I'm talking to Professor Cliff Rosendahl, someone whom many of you will have been taught by in the past. Cliff has had an amazing career in skin cancer medicine with many publications and a number of books. I'm not going to go through the whole story, that's his job. But welcome, Cliff.
Thank you, Tony. Nice to be here.
Can we start with the early days? I think you were at the University of New South Wales and then you ended up in Capalaba, which is eastern suburbs of Brisbane. How did that journey evolve?
Well, I'm from New South Wales as a high school student, and so it was natural to apply for a New South Wales university, and actually applied for the University of New South Wales. And I commenced there I commenced studying medicine on the year that Armstrong walked on the moon, 1969. So that's a long time ago. And when I finished there after 6 years at UQ, at New South Wales University, I straight away came to Queensland because that's what I'd always wanted to do.
Okay.
And that's from reading novels when I was a kid, set in Gundawindi in Western Queensland. And it's funny how things influence you, but that's where I went. And I originally intended to study surgery, but early in my time in Queensland, I took a role as a medical superintendent with the right of private practice in a Western Queensland town, Tara, which is not far from Gundawindi, actually. And I was planning to stay there for a year, but I stayed there for 7 years. And by that time, I was pretty established in general practice and quite enjoying it. And so I came back to Brisbane when my children got to the age where they'd have to start going to a school based in the city. And it went from there. I was just in general practice as a generalist GP for most of my career. And the transition to skin cancer medicine came after 2000, after the turn of the millennium. Okay. Yeah.
But certainly many years in rural Queensland, then eventually evolved into suburbia, Brisbane, mainly because of your children, which is not an uncommon story, is it? That's for sure.
Yeah, look, my background in rural general practice was a great entree into general practice in the city. It gave me a lot of confidence, of course, having been in the bush for 7 years. And also I got an interest in forensic medicine because when you're in the bush as a GP as a medical superintendent and the only doctor in the district, you get to be the government medical officer. And so that involves collecting specimens and doing examinations of people who've been victims of crime, like homicide or rape. And that fostered an interest in forensic medicine, which I carried on when I came to Brisbane as a government medical officer for the south side of Brisbane.
Oh, wow. But your first melanoma diagnosis was about 1976, is that right?
It was, and that was my first year in the bush, and that's where diagnosis happened. That was my first year in private practice, which is 49 years ago, actually a long time. And you can see there was a big gap between 1976 and 1982 when I had my next melanoma.
So I'm guessing that diagnosing a melanoma in 1976 is a little bit different to today, isn't it?
Well, strangely enough, it was a melanoma in situ.
Oh.
Like in my 7 years in the bush, I didn't encounter an invasive melanoma, and I didn't have any deaths from melanoma. So I didn't get any feedback subsequently that people died of melanoma that I'd treated previously. So there was something about the 1980s and onwards when melanomas, I think, became more prevalent. We know that there was something happened between 1923 and 1966 that caused the current epidemic of melanomas. Something happened worldwide. And back in the 70s, they weren't as common. I'm sure it was. It's not that we weren't diagnosing them, they weren't as common. And so from the time I came back to Brisbane in 1983 until about 2000, I was just getting very sporadic melanomas, but a much higher proportion of those died. A much higher proportion of those were invasive. And from the graph I've put together from 1976 to 2003, in the first 30 years, there were 84 melanomas that I diagnosed. In the last 17 years, between 2007 and 2023, there were 1,032.
Wow. Big difference, isn't it?
And in that first period of time, in that first 30 years, out of 84 melanomas, there were 5 with adverse outcomes and 3 with death. That 5 included 3 who died. In the last 17 years, from when I started recording data on SCARD, out of 1,032 melanomas, there were only 10 with adverse outcomes compared to 5 out of 84, and 3 deaths, the same number as in the first 30 years.
Okay.
So out of 84 melanomas in the first 30 years, there were 3 deaths, and out of 1,032 melanomas in the last 17 years, there were 3 deaths to date, which people can still die, of course, but that's current data.
So when did this transition start happening for you, where you were in general practice and you decided you wanted to have more of a focus on skin cancer medicine rather than a general practice role?
Well, that was driven by finding more melanomas, just encountering more melanomas. And at the same time, in the early 2000s, about 2004, 2005, the Skin Cancer Society Australia was created by Peter Bourne, Richard Johns. They got speakers out from Europe and America, and I went along. They were great conferences, and Ian McColl started the blog, the Skin Cancer College of Australia blog, and that was a really inspiring experience, as you know, because you were there. People put up cases every day, and lots of people came and commented, and it was a very vibrant experience. And that got me really fascinated. And people like Scott Mengie gave talks, and the melanomas in particular and other skin cancers that he photographed were fantastic photos because they were all with non-polarized dermatoscopy. So the blues were really vibrant. They weren't sort of, affected by polarization. And it was like starting when you go scuba diving for the first time. Everything was wonderful, like a new world, and colorful. The metaphoric terminology was very artistic.
Well, that was colourful too, wasn't it? Yes.
Fat fingers and blue-white veils and spermatozoa, it was really quite fascinating. And personalities like Iris Zalodek and Jeppe Argenziano and Ashmar Goob and then Harold Kittler. And they were all very, very intriguing people who had great passion, and it was catching.
So this was all mid-2000s where that first meeting occurred down at the Gold Coast. And then the Skin Cancer Society was formed at that stage. And then,
I didn't actually attend that very first one. I didn't attend that first one, but it was subsequent to that I actually attended. But the feedback on the blog from that first conference was really, really good, and couldn't miss anything after that.
Okay. And when did you first pick up a dermatoscope?
Well, that's a bit embarrassing because my first dermatoscope cost me $40,000. And that was in 2005 when I bought a Molmax.
Right.
I didn't have a handheld dermatoscope when I bought the Molmax.
Okay.
And I was so disappointed with the Molmax. After a month, I went and paid them to make and manufacture a non-polarized camera for it. Because the polarizing camera, you couldn't see any blues and very little grays. And they were the colors that I really wanted to see. And so I spent another $1,000, got a non-polarized camera, and then I used it for about a year, but then I stopped using it, just went to the handheld after that. And one of my colleagues in the practice, a generalist GP, he used it for quite a few years.
Do you recall what your first handheld dermatoscope was?
It was a Heine Delta 20.
Delta 20, yep.
So that was a non-polarized dermatoscope.
Yep.
And when I started taking photographs, I got a Dermlight fluid, which is a non-polarized Dermlight. Now, Dermlight were the ones who introduced and invented polarization. For people like me who wanted non-polarized color, they had the Dermlight fluid. And I used that for all my photography right from the very start until I transitioned to taking polarized images as well around about 2010. And then I got a Dermalite DL3, I think it was, then DL4,
Okay.
so on. So photographs that I've published have only been taken with the Dermalite fluid and then the Dermalite DL3, 4, and 5.
But gee, it was a big investment at the start with the Molmax, wasn't it, to go to $40,000?
It was embarrassing, but that's
Not embarrassing. It's what was around at the time.
well, it showed that I was actually committed and willing to make an investment, although it turned out not to be a very profitable one. But a lot of people use the Molmax and like it. Like I know Jeff Keir used the Molmax and really got fantastic results. And I tell Jeff that he invented polygons because there was no grey to help him with the Molmax, and he had to find something else. But he says that's not accurate. But that's what I reckon.
And it wasn't long after that SCARD evolved, SCARD being the database for collecting this data about skin cancers.
Yeah, the skin cancer database was originally called the Audit, but my supervisor, my PhD at the time was David Wilkinson, and he said we needed a sexier name than the Audit, the Skin Cancer Audit. And so he came up with Skin Cancer Audit Research Database, or SCARD, and that's how it got its name. And that was a collaboration between myself and Tobias Wilson, who at the time was a young fellow, no university qualifications, no tertiary qualifications, but an absolute genius with setting up a database that was robust enough and flexible enough. Initially, people had to install it on their computer, and the data stayed on their computer. And then he transformed it into a cloud-based database.
All the original Excel spreadsheets for it, yes.
Yep. And the reason for it was that I didn't know what was normal out there. I didn't know what was normal for GPs or any clinicians working in the field of skin cancer as far as how many harmless things you could find, like the NNT ratio, the number of benign things you cut out for each melanoma you found. I didn't know how many BCCs was expected to be for every melanoma and how many SCCs. And we didn't have any metrics as to what was actually happening in practice. So it was a way of recording data in real time, as you found lesions, recording it, and putting the data up there, putting in what you predicted the lesion to be, what the reason was for the procedure, whether it was to see if it was a melanoma or a non-melanoma skin cancer, or whether it was just cosmetic. And so that was the rationale behind putting it together. So we found that we could use it to track our specimens. So when we had a specimen scheduled, it was spread on the yellow on the spreadsheet. When the biopsy was performed, it would go to orange. When you got the results, it went to either red or green. It was comparing it whether it needed any further treatment or not. And then we could harvest data. So the doctors signed an agreement to have their data researched. So look, it's been going now for a long time.
Well, 18 years of it now, isn't it?
18, 19 years. And there's been quite a few publications on the pooled data. And the doctors that started using it, a lot of them are still using it because it's invaluable as a tracking tool.
I've got every single specimen of mine in there for the last 18 years. That's true. But did this start as part of your PhD?
It started before that as just out of curiosity and wanting to put together something for me to track my specimens. So to help me in my practice.
It was really about the original objective for the whole SCARD database was about you tracking how you were going so you knew what was real and what wasn't real.
Yeah, so I knew what was happening. And also, even now, we can look back and if something's still red from 2 or 3 months ago, it needs following up. In other words, it's something that requires treatment. It hasn't been treated to resolution yet. And so I use that in real time. My nurses actually keep an eye on that. And when a patient comes in, they tell me if something's still red on SCARD, there's something that's still outstanding, and we follow that up. So that was the original plan behind it. And then we got other doctors doing it because that's when my PhD started, and we thought we better start looking at some data. And I remember when we had 30,000 specimens on SCARD, I didn't have a clue of how to analyze this. So that's when we went to UQ. We spoke to David Wilkinson and Peter Sawyer, and they provided a statistician and all of the intellectual backup that we needed to know what to do. And it's gone from there, and now there's nearly 2 million specimens on SCARD. and it's increasing
So,
by about 50,000 every year.
so at this stage, you've got a busy general practice. You're evolving yourself more into a skin cancer doctor. You're reading and researching and studying more about skin cancer. And then you decide, oh, since I'm not pretty busy at the moment, I might just do a PhD as well. Is that the idea?
Well, actually, it was a very busy general practice. It was a
Mm.
fully operational general practice, and it mainly relied on me. So we didn't have a lot of doctors then. I did the PhD because I was doing the research anyway.
Mm-hmm.
And so David Wilkins said, well, why don't you put in a proposal for a PhD, which I did, and it got accepted. So all the things I did for my PhD, I was doing anyway. So the PhD was a bonus.
Fair enough. And were you doing much research in general practice before you started doing the skin cancer work?
No, no, I did a little bit when I was in Tara, and I got some medical students. You take that data and they did something with it. But I wasn't in a big way into research in general practice. It was when the scar landed, and Harold Kittler, I met him, and we had, Alan Cameron and myself had lots of photographs. So he's turned
Okay.
our data into really high quality scientific publications. Like, he had a couple with him as the senior author, which were published in Nature, which is quite an achievement. That sort of half my PhD was scarred, the other half was under the help of Harold Kittler. Things like the dermatoscopy of squamous cell carcinoma and keratoid xanthoma. We published the importance of white circles, and then we published how dermatoscopy increases the accuracy of diagnosis of pigmented non-melanocytic lesions like SCC and BCC, as well as melanocytic ones that hadn't been published before. So lots of collaboration with Vienna University Medical in Vienna, and that's a big part of stuff we do ongoing.
Oh, that process of publication is a pretty scary thing the first time you do it. So having that mentor of Harold to help you with publication must have helped a lot.
The first publication that I did pretty well by myself was on the first Merkel cell carcinoma dermatoscopy. It had never been published in the world, a Merkel cell tumor with dermatoscopy. And I remember we did it with Iris Zaladic, not with
Mhm.
Harold. And I remember my first submission of that paper, we spent a lot of time putting it together, and it was rejected within 60 seconds of the submission. And I was really angry. They obviously haven't read that. Iris Zaladic's one of the co-authors, But anyway, we redid it for another journal, and dermatologic surgery, and they accepted and published it. And but that was my first experience of something I'd put together myself. And it was terrifying because when we published the smallest melanoma in the world in 2011, that went through a review. And it was scary because when the review came back, you thought you'd been rejected, and it was very hard to do what they wanted you to do. And when we submitted the first SCARD paper, which you were a co-author on, it was scary because they asked us, well, how can you tell if people are moving between doctors on this database? You've got multiple doctors. What if a patient's moving between two doctors? That'll show up as two lesions, and then Toby came up with a concatenate whereby he could, on an anonymous database, track movements of patients on a database up to 15 million people. He could track the movements of a patient between doctors. So when that first comes up, we think, well, they're going to reject it because people might move between doctors and it'll ruin the data. But no, it was a learning experience.
Oh, yeah. Speaking of learning, teaching was obviously one of the next steps as well. Were you doing much teaching in the general practice setting, or was it really started when you started doing more skin cancer?
No, I did no teaching in the general practice setting, and that started. I think the first one that Alan Cameron and I gave, we had 4 people turn up, and I think 3 of them were still referring patients to him. My first presentation in front of a big audience was at Barcelona in 2009 at the IDS
Oh,
conference,
wow.
and I had 3 presentations to do. They were 12 minutes each. We'd submitted abstracts. I was presenting on the basis of the abstracts. And I was so nervous I didn't sleep at all that weekend. And by the end of the weekend, I was had it. but we'd actually submitted a poster, and in the final session, I was there half asleep, and suddenly the picture of my poster appeared on the screen up the front, this huge, enlargement of my poster, and it was because we'd won the best poster award. And that woke me up, but I didn't know what to say when I dig up the front. But that was a great experience. But that was my first presentation, that 12-minute presentation.
Wow.
So I've done a lot since then.
Most of us, start off with a bit of imposter syndrome. We get up in front of an audience and we're sort of, why on earth are they listening to me? So when you started presenting because you had some research data, did that make it easier to start the teaching process?
It helps to have something to talk about, but I really enjoy the teaching now. I do a lot of teaching in Australia and to audiences, and overseas. I travel at least 3 or 4 times a year, and the audiences are typically like 100 up delegates, and do teaching for skin cancer symposiums. They're a New Zealand-based group. We go to Europe, and they also go to New Zealand several times a year, and also for Sonic, and they have their skin cancer courses, which they present to GPs. They're really high quality courses. And so with other presenters, including Simon Clark, Amanda Oakley, Mason Hassani, Raj, and quite a few, John Pine, we present very regularly, and it's well received. And that's, of course, apart from the teaching at the University of Queensland, is where I was course coordinator for over 10 years with the UQ skin cancer program. And it was, when I started teaching, I started learning a lot more because people ask curly questions. And so it's a great learning experience, and it's a nice way to learn.
I think you're right there that the best way to learn is to teach, because they ask you questions and make you think about why do you think a certain way.
Yeah.
But this has then evolved, from that initial research and the initial education into things like chaos and clues. I mean, there was quite a few algorithms around, and then to go and do a big piece of work like that to get your whole new algorithm going is quite a lot involved. What inspired the developing of chaos and clues?
Well, the foundation of that was laid by Harold Kittler, because he had his revised pattern analysis, and his process, which he recommended that we use, involved patterns, colors, and clues. So you look at a lesion with a dermatoscope and you work out the pattern, and the patterns were in order: lines, pseudopod, circles, clods, dots, and structureless. And you could predict based on the primary pattern, and whichever of those patterns occurred first, or was the primary pattern, and that would limit the differential diagnosis. So you look at the patterns, and you look at the colors, and then you look at the symmetry or asymmetry of the patterns and colors. And then you look at the clues. And that was the order. And I just, looking at it, and I thought, color, pattern and color, okay, chaos. Put the two together, chaos and no chaos, and the clues. So we just modified the clues a little bit. We added polygons or lines angulated to the clues. So that's where chaos and clues came from. It was just a simplification of patterns, colors, clues.
And an extension on what Harold put together for the basic pattern analysis.
Yeah. And in the latest version, which is in the latest version of my book, which is about to be published, I've called it Chaos, Clues, and Exceptions, to emphasize the point that once you've decided a lesion is a lesion of concern, and that might be because the patient's concerned about it, or because you can't give it a confident, specific, benign diagnosis that makes it a lesion of concern, then if you've looked for chaos and clues and you haven't decided to condemn the lesion, you must consider it the 4 exceptions before you do that. Exceptions become an integral part of chaos, clues, and exceptions.
I was going to say it's one thing to develop an algorithm of like chaos and clues, but it's another step to go and actually write a book. And dermatoscopy and skin cancer, that handbook for hunters, is obviously a lot of work in doing that, and especially the tiger hunt on the skin. That sort of came from the skin cancer blog. Do you remember how that original hunting analogy evolved with the blog and then into the book?
Yeah, I took it to the blog because, for example, when I went to Tara, I went there because the hunting was good. And I wouldn't hurt a mouse now, but back then I used to enjoy hunting wild pigs. And so I think it's a very natural human, drive to hunt or gather, as Oksana, my co-author, would say. She's the gatherer. And so I thought it was appropriate because we're there and the jungle is the skin, and that's where we're hunting, and we're looking for things that are dangerous.
So you've evolved from hunting large wild boar into hunting the smallest pigmented spot you can find on the skin.
Well, it's sort of like that. And when we had the tiger hunt, no one's going to hurt a tiger, but there's, inspiring dangerous animals. And 100 years ago, they used to get hunted. And one of my favorite authors, Jim Corbett, wrote The Man Eaters of Kumaon. And that was a book that really inspired me because he was a gentleman, but he was a good hunter. And he would only hunt a tiger when it had killed 1,000 people. And he wrote some very, very good stories that I enjoyed. And so we had the tiger hunt on the blog, and obviously, you can imagine multiple cases are presented, and the idea is you've got to pick the ones that are dangerous. And so it was a natural analogy.
And then the process of writing a book, I mean, it's a lot of work involved in that. How did you approach the concept of, I'm going to put together an entire textbook?
Well, on the UQ Skin Cancer program, I was running the intake course, which needed to teach microanatomy, the history and evolution of skin cancer and of skin, and basic diagnostic methods, how to do a clinical examination, how to use the dermatoscope, and then how to diagnose pigmented and non-pigmented lesions and so forth. So I put together a course textbook, which was just multiple references drawn together and referenced, but not my own original work, mainly work of others. And so I thought, well, after I've been doing this for a few years, it would be nice to have a book that was created specifically for the course, for the syllabus, and also useful for people who were not able to do the Masters of Medicine course. And so that's where the idea of the book came in. And it was a major collaboration between myself and Oksana Marazava, who's the co-author. And she was my nurse at the time. She's now a dermatologist. And I gave her 100,000 photographs to sort through to find the best 500 for the book. And she did it. She sorted through 100,000 photographs from 25,000 lesions.
Wow.
So they were clinical, close-up, polarized, non-polarized. I couldn't have done that without her. And things like the index for the book at the end, I couldn't do that, but she did that. And now for the current edition, which is in press at the moment.
I was going to say that comes out next month or so as the second edition.
Probably it'll be out at the beginning of September. If we've got the original edition, then the updated edition, and now the second edition. And this is a major rewrite, lots of new content. But I've got two new co-authors, still myself and Oksana, also Mohammed Reza Hassani from North Queensland, and Simon Clark. Now, Mohammed this time is the expert with Photoshop and putting together collages of images, and he's doing the index. So, and Simon Clark's rewritten the dermatopathology content and gone through the whole book, intellectual ideas. So this is I'm really looking forward to it coming out. It's got a very interesting cover, which is totally different to the first cover, which I won't go into any further. But it's a very interesting cover. And
you mentioned that you've evolved Chaos and Clues to include exceptions in this book. What other sort of new parts to this book have you found the need to add?
Exceptions are always a part of Chaos and Clues, but we've made them an integral part of the flowchart, not just something you think about sometimes. The other new content is prediction without pigment is morphed from a decision algorithm to a diagnostic algorithm. I've added a chapter on photographic technology and skin cancer diagnostics. I've expanded the chapter on melanomas to include a lot more melanomas, including melanomas, mucosal melanomas, nodular melanomas, melanomas that metastasize, nail apparatus melanomas, and melanomas that cause death, fatal outcomes. Being enhanced in the chapter I've created a new chapter on nevi, which was part of the one big chapter at the end, but now it's just on its own. A major part on the so-called dysplastic nevus, how the diagnosis of a dysplastic nevus clinically has no relevance at all and unnecessarily confounds therapeutic decision making. So that's a big part of it. And all the graphics have been redrawn. There's some new graphics and a lot of photographic material has been added. So it's a new look, new feel, and obviously we've updated it where it was appropriate.
So all these things are an evolving journey, aren't they? From finding a few melanomas to finding more, to starting to study them, to learning more, to research, to teaching. So for a young doctor who is starting up in practice now, and how do you think about advising them about how to approach skin cancer work, and what do you think they should do about the changes in technology coming up? For example, what would you suggest to someone who's starting up in practice today, but how they might set up a skin cancer practice?
My focus has been on satisfying my own personal curiosity. It hasn't been on making money. I haven't built up a big skin cancer clinic. We've now got 13 doctors, and half are in general practice and half are in skin cancer, but they're not all practicing full time. So my advice would be, do it if you really enjoy it. And if you don't enjoy it, then improving your knowledge is a good way to start enjoying it a lot more. And I think I would advise anyone getting a skin cancer practice to photograph everything they treat, everything. Now, by photographing everything, I probably made a lot less money if I wasn't wasting my time photographing. But I got the first Merkel cell with dermatoscopy. I published white circles before they'd ever been published before. They hadn't even been named before. And, when I encountered a small lesion, which turned out to be the smallest melanoma, I'd taken really nice photographs of it, so it was publishable. These are the sort of things, if you take photographs, regardless of whether you know what it is, if you're going to treat it and cut it out, then I think it's good to take photographs. Take the time to do it properly. Use immersion fluid. Don't take photographs that no one's going to enjoy watching yet because they're poor quality. It's a lot easier now. You can do it with an iPhone, and the modern dermatoscopes have magnetic attachments for the dermatoscope, for the iPhone, and you can get good quality pictures with iPhones if you use the right equipment. Okay, I see some really poor quality photographs taken, and I see some good photographs taken. And some equipment does better photographs than others. I'm not going to go into any details there, but you need to know. It's like knowing that one particular dermatoscope out there doesn't show polarizing specific features, even in polarized mode. You need to know that before you spend $5,000 buying one.
Yeah.
And that company went back, and when I published the one that was giving the problems, they went back and developed one that is superb, doesn't give problems anymore. And so
Right,
these are
pictures
things
are
that you
worth
can
1,000 words, aren't they? But some pictures are worth 10,000 words.
Yeah, absolutely.
A good photograph is so valuable. Isn't
it? Yeah. And when you can publish something that makes a really multinational big company go and develop something new because they're going to look stupid if they don't, that's satisfying. That's satisfying. So take photos and record prospectively on SCARD or something equivalent. Lots of pathology companies have a bit of paper you can turn over right on the back. It's not as good as SCARD, but it's better than nothing. You got to monitor your performance and collect data on yourself. And I think this enhances the enjoyment of work.
I think you're right, though. If you enjoy the work, then it's easy to take those photographs, and it's easy to do that extra work and the putting stuff to the SCAR database, and you just keep on getting the rewards back from it every time, don't you?
Yeah. When people ask me why I teach, why I do presentations, and why I taught at UQ, I tell them it's not to help them save lives, it's to help them enjoy their work more. That's my motive, is to help students or doctors or whoever enjoy their work more, because that's what it's all about. And if you enjoy it, you'll do it better.
Excellent. Cliff, thank you so much for your time. That is just fantastic. And it's been a magnificent journey that you've been on. And you've helped so many people. They've all learnt so many things from you that, well, I'm sure they've all enjoyed hearing about the journey you've undertaken and what it's been like.
Thanks, Tony. It's a pleasure to talk. Thank you.
So that's it from us today, and I hope you found this episode helpful and perhaps even picked up something practical to use in your clinical work. So I want to say a big shout out to HealthCert for all their help with production and distribution of this episode. They do lots of good things in the skin cancer education space, including helping get this podcast to you. So if you're looking for other skin cancer education, it's worth looking them up. But thanks for listening, and I'll see you next time on Life by a Thousand Cuts.